Hello, my name is Pratik Lamsal. Today I'll be presenting my literature review on mitigating cognitive load in clinical practice through AI-enhanced EMR design as a part of my work for CS 6795. Although EMR were designed to streamline care, they often burden clinicians with fragmented interfaces and overwhelming documentation demands. From my own experience managing clinical dataset, I've seen firsthand how unintuitive systems lead to errors and inefficiencies. I use cognitive load theory as my foundation. It breaks cognitive demands into three types: intrinsic, extraneous, and germane. Most EMR fail by increasing extraneous load and disrupting germane learning. Despite CLT insights, commercial EMRs rarely address psychological stress or decision making. There is a lack of frameworks integrating CLT, HCI, and real clinical constraint. This leaves design improvement disconnected from theory. AI tools like large language models so promise in easing workload, but if not aligned with cognitive principle, they risk adding complexity. My research asks is how do clinicians perceive EMR cognitive impact and how can AI HCI tool be designed to help? I explore usability pain point, map them to CLT, evaluate AI strategies, and propose human-centered design guidelines. I synthesize literature to highlight cognitive design failures, evaluate AI tools, and recommend a cognitive aligned approach to EMR redesign that prioritizes clinical reasoning. I conducted a systematic review of the past 15 years across PubMed, ACM, and Google Scholar. I organized findings into four themes: cognitive theory, EMR challenges, AI capability, and integration gaps. My work is grounded in Sweller's CLT and builds on studies by Hoare, Kim, Budd, Cabral, and others across EMR usability, AI design, and clinician burnout. Multiple studies reveal that EMR-induced stress comes from consistent design flaws. AI tools like GPT-4 and Naomi show strong potential to ease clinician workload, but if not properly integrated, they risk adding complexity than reducing. Despite major AI advances, integration still fails when systems don't align with how physician thinks. I refined my methodology by thematically linking cognitive science and HCI, filtering for empirical rigor, and mapping Sweller's split attention effect to the eye-patient phenomenon to focus on clinician burden. While AI shows clinical potential, its real-world utility remains low due to poor integration. The biggest issue I found is a disconnect. AI research focuses on what's technically possible but often ignores how clinicians actually think and work, creating a major gap that must be bridged. This framework shows that EMR design must start with a cognitive load theory, integrate AI tools thoughtfully, and be grounded in human-centered design that fits how clinician actually works. Multiple studies shows that AI alone doesn't reduce error. Without cognitive alignment, even advanced tools like GPT-4 can introduce new risks instead of solving old ones. Despite years of innovation, EMR problems persist because design focus on features, not cognitive fit. In conclusion, improving EMR means more than upgrading technology. We must reduce cognitive load, close the AI implementation gap, and design system that truly supports clinical reasoning. To truly improve future system, cognitive science must shift from critique to creation, guiding AI development from the start, especially in high-stakes settings like healthcare. Thank you.